Hello, this is Dr. Nina Kim from the University of Washington. In this mini lecture, I will be providing an overview of Bulevirtide, the first antiviral agent directed against hepatitis delta infection. Bulevirtide is a first-in-class entry inhibitor for chronic hepatitis D. It is a long-awaited therapy. Consider this timeline, which is not to scale given the decades between viral discovery and targeted treatment. For almost 40 years, we had only one form of treatment. Off-label interferon-based therapy became the de facto standard care, but its use was limited by substantial side effects, suboptimal virologic response rates, and viral relapse in more than half of those who responded. In 2020, then 2023, Bulevirtide received conditional, then full approval in Europe for adults with compensated liver disease, and in May 2026, it received approval from the U.S. Food and Drug Administration. HDV affects about 10 to 20 million people worldwide. It is a defective satellite RNA virus that requires hepatitis B surface antigen as its envelope protein for propagation. In other words, having chronic hepatitis B is a prerequisite for chronic hepatitis delta. HDV co-infection greatly increases the risk of severe liver disease and is in many ways the most severe form of chronic viral hepatitis. Compared with HBV monoinfection, HDV viremia is associated with a 2 to 4-fold higher risk of liver-related complications, including hepatocellular carcinoma, decompensated cirrhosis, and death, making HDV treatment all the more urgent and necessary. Bulevirtide is a synthetic lipopeptide that binds to and inactivates the NTCP. The NTCP is a bile acid transporter expressed exclusively on hepatocytes. It also happens to be used by both HDV and HBV to enter the cell. By blocking this receptor, Bulevirtide prevents HDV from entering new hepatocytes, thereby stopping the spread of the virus within the liver. Bulevirtide is currently approved for use in the treatment of chronic hepatitis D in adults without cirrhosis as well as those with compensated or child A cirrhosis. This has not been studied in persons with decompensated liver disease. I will be reviewing the key features of the drug in subsequent slides. One thing I wanted to call out is the discrepancy between the prescribing dose noted here as 8.5 milligrams, and the higher dose that was reported in the clinical trials, which was 10 milligrams. A dose recovery study, completed after the main registration trials were done, found that the actual dose used by the 10 milligram participants was 8.5 milligrams, and this distinction is reflected in the label. The pivotal trial of Bulevirtide monotherapy was MIR 301. The 48-week data was reported in this 2023 New England Journal paper. This was a phase 3 open-label randomized trial comparing 2 milligrams and 10 milligram daily doses against a control arm where the Bulevirtide was delayed for 48 weeks. For the 3 endpoints shown here, you can know right away the differences in response between the treatment arms and the delayed arm. Additionally, for both doses, more patients had decline of viral level to 2 log or more, but not complete viral suppression to undetected. The majority of patients who showed a suboptimal virologic response to Bulevirtide still went on to improve their ALT levels during treatment by week 48. Combined response, which was defined as HDV viral decline to 2 or more logs, or undetectable with normal ALT, was ultimately seen in 45 and 48% of participants in the 2 and 10 milligram groups, compared with only one individual in the control group. These virologic and biochemical changes were also associated with improvement in liver stiffness measurement by transient elastography. These same participants were followed to assess long-term efficacy out to 144 weeks, or approximately 3 years, with the results demonstrating sustained efficacy with longer treatment. Although it is worth noting that the combined response rate did not improve much after the second year of therapy. Post-treatment follow-up was also conducted after the end of treatment. Notably, most participants lost their virologic response with treatment discontinuation, with HDV RNA levels rebounding. And along with this loss in virologic suppression came the loss in normal ALT, or return to elevated ALT levels post-treatment for many individuals. The risk of post-treatment hepatitis flares is really the main safety concern when it comes to Bulevirtide. ALT flares of greater than 5 times the upper limit of normal occurred in 41% of patients after stopping Bulevirtide, and ALT flares of greater than 10 times upper limit of normal occurred in 10%. Patients with cirrhosis were particularly at risk. During this post-treatment period, 4 patients also experienced clinical decompensation events: esophageal variceal hemorrhage, ascites, hepatic encephalopathy, and HCC, One ascites case was associated with post-treatment hepatitis D exacerbation. These events were serious enough to merit a critical warning alert, a boxed warning that severe acute exacerbations of hepatitis B and D can occur after discontinuation, especially for individuals with cirrhosis who are at risk of hepatic decompensation. Monitoring hepatic function closely with clinical and lab follow-up is advised, with a close eye on ALT, HBV viral level, and HDV RNA for at least 6 months after stopping therapy. Stopping treatment should only be done if close monitoring can be ensured. The importance of this needs to be emphasized. At the moment, the recommendation is to continue therapy if clinical benefit has been observed. As far as on-treatment safety, bulevirtide was generally well tolerated. In the 96-week study, the most common adverse events reported were injection site reactions, headache, fatigue, and pruritus. Similar safety profile was observed through week 144, and no one discontinued bulevirtide due to adverse events. There were a few additional things to note regarding bulevirtide on the issue of safety and drug effects. Because it blocks the NTCP transporter, bulevirtide can cause a dose-dependent increase in total bile acids. In the trials, this increase remained largely stable through the course of treatment and reversed with stopping. This is not considered liver toxicity, but more consistent with an expected drug effect due to the mechanism of action that is not at this time considered clinically significant. These bile acid elevations were asymptomatic and did not correlate with pruritus or other adverse events. The package insert, in fact, does not recommend doing any monitoring of bile acids during therapy. The recommended U.S. dose is 8.5 milligrams once daily via subcutaneous injection. Bulevirtide comes as a lyophilized powder that requires aseptic reconstitution with sterile water for injection. And once reconstituted, must be used immediately rather than stored for later use. Patients will need to be trained to do this, as well as to rotate injection sites. A number of questions remain about bulevirtide. The ultimate duration remains undefined. It appears to have high barrier for resistance, and no confirmed cases of treatment or emergent resistance have been reported to date. Prescribing guidelines currently suggest continuing the medication as long as there is clinical benefit, as it is unknown when or if monotherapy can safely be stopped without risking viral rebound. Results from combination trial MIR 204, which looked at bulevirtide with PEG interferon, did suggest a potential path toward finite treatment, with 46% of patients maintaining undetectable HDV RNA 24 weeks after stopping a 96-week regimen, compared with only 12% with monotherapy. But all the same precautions regarding stopping bulevirtide apply here as well. Additionally, while improvements in liver stiffness were observed, it is unclear whether this represents true fibrosis regression versus merely a reduction in hepatic inflammation. Current approvals are based on surrogate endpoints, HDV viral decline or ALT normalization, and long-term data are still lacking on whether these responses lead to a reduction in hepatocellular carcinoma or a lower risk of death. So in summary, bulevirtide provides a long-awaited option for a high-need population. Monotherapy is effective and safe for long-term use in patients with HDV and compensated liver disease. For more details on bulevirtide, including data on the combination with PEG interferon, be sure to check out the medication section on the Hepatitis B online website, where you will find a free downloadable slide deck of the main clinical trials. Thank you for joining me today.
The production of this Hepatitis B online mini-lecture was supported by funding from the Centers for Disease Control and Prevention.